Hello, everybody, and welcome to the badEM podcast. My name is Daniel Still, and I'm your host. badEM stands for Brave African Discussions in Emergency Medicine, and this is a platform we use to try and find African solutions for African problems. This month we are talking nursing, and I'm delighted to welcome Dr Meghan Botes, who's a professional nurse from Joburg who has specialized in emergency care nursing before moving into nursing education, doing various research projects, including a PhD in the topic. But she will tell you more about that. We chat about how important training is for nursing in our setting and for the primary care facilities that operate above their level of design, and how that training has so many more benefits than are apparent at first. We will talk about teamwork and communication between doctors, nurses, and patients, and how this can improve. And then we touch on some deep-rooted issues in South African healthcare that everybody can contribute towards in their own way. As always, everything said represents our own personal opinions and does not represent any organizations that we may represent. Without further preamble, welcome to the show, Meghan. Would you mind starting us off by introducing yourself and giving us a brief background of your career so far?
Sure. So my name is Meghan Botes. I am an emergency nurse by profession. I did my basic training, my undergraduate degree at Wits University. I've been at Wits University for most of my adult life. I then went on to do my community service and some clinical practice at the Charlotte McCracken Academic Hospital in the trauma and emergency department. And thereafter, I did my specialty training in emergency nursing along with my master's in emergency nursing and then nursing education. And then I did my PhD in nursing as well, with an emergency nursing focus. And so my current position is I lecture at Wits University in the Department of Nursing. I teach undergraduate nursing, and hopefully when our courses are accredited, I will be teaching the postgraduate diploma in emergency nursing. So that's my career in a few sentences.
Awesome. And let's move straight on to those courses. You presented your research at the African Conference for Emergency Medicine. Would you mind telling us about that in a brief, doesn't have to be too brief, way, just explaining what the research was for and what you hope to get out of it?
Sure. So I presented at the African Conference on Emergency Medicine in Botswana last year on a project about the rollout of the basic emergency care course in South Africa. So the WHO had developed a emergency care course for frontline providers dealing with emergencies in all settings, but basically frontline healthcare providers, doctors, nurses, clinical associates, paramedics. And the course is basically, it was developed by the WHO and the International Committee of the Red Cross. And here on our side of the world, we get our accreditation through the African Federation of Emergency Medicine. So where the project started was actually from my PhD. My PhD's focus was looking at strengthening emergency care at primary healthcare level. So what I did in my study was I did basically an investigation to be able to describe the strengths and weaknesses of emergency care at the primary healthcare level and what the frontline providers were experiencing. And the findings of my study were that in South Africa, we have a problem with emergency care at that level. In general, we don't have a national plan for emergency care. And that filters down at the lower levels because at PHC facilities, we all know the focus is chronic care and preventative and promotive health. And emergency care is not quite the focus. But then you have these strange things like the ideal clinic framework that said that community healthcare centers have to operate with a 24-hour emergency department. So it's just throwing an emergency center into a setting that's not prepared with healthcare providers who are not equipped. And so their experiences were quite harrowing, listening to them talk about the amount of trauma, the amount of acute illness and injury that they see at that level, and just the lack of resources, the lack of training. So from that study, one of the biggest findings was that there's a need for training. And so that's what we did with the basic emergency care project. We rolled it out for nurses specifically because we know in the primary healthcare setting, nurses are the bulk of the workforce. And we implemented it with nurses in 3 different community healthcare centers in Gauteng. So we aimed to train at least 70% of the nurses in each emergency department. We did train 100%. I think in one we got 99%. And the uptake was fantastic. The managers were just sending more and more people from all the different units. And that's what I presented at the conference, was findings from a part of the project where we did obviously the normal knowledge pre and post test, confidence pre and post test, self-perceived competence in emergency care, which all improved amazingly. Also, we're currently just about to publish on the qualitative aspect. So 6 months later, we went back and we interviewed those nurses, asking them, was the knowledge gain sustainable? Do they still use it? Do they still use the skills? And then we also interviewed non-BEC trained members of the team, mainly doctors who weren't a part of the study, and we asked them, have they seen a difference? And the feedback has all been phenomenal because it was so needed. So that is what I presented in Botswana last year and what I'm still busy with.
Awesome. So those are the courses that you mentioned that you are hoping to roll out fully when your project that you're working on at the moment.
Yeah.
And just to touch on something you said there, obviously the Ideal Clinic said that the primary facilities have to have these emergency units, but it doesn't matter what anybody says. Patients hardly ever know the difference between facilities and where they should or shouldn't go. So, and the level of trauma and the emergencies that just go to the closest place that they can, where they think that there could be a doctor, is what we see all the time in South Africa. So I think this training is, well, you obviously know it's hugely needed, but that is another aspect of why it is so needed.
Yeah, and I mean, if you look at how the community healthcare center is set up, those emergency departments are meant to run as mini trauma centers because they are 24 hours. They are situated directly in the community, so it's the first line. So even if there is a hospital nearby, everybody knows, because that's policy. Everybody knows you start at the clinic, whether it's trauma or an emergency. So they see everything. I always say, in our big level 1 trauma centers, the nurses and doctors, they think they've seen everything. You haven't until you worked in a CHC emergency department, where organophosphate poisoning comes in the numbers by the day. They have trauma, they have motor vehicle accidents, they have anything you can think of. Complicated with those chronic patients sitting in a line who complicate while they're waiting for their medication. So yeah, it's crazy.
I'm going to jump ahead because you mentioned one of the things that you did in the qualitative part of your research was interview doctors about the difference that they'd seen. How do we incorporate training from a team-based approach when it comes to the difference between doctors and nurses, and then further break that down into the different levels of doctors and the different levels of nurses? Obviously, there are multiple experience levels and qualifications of both, and some training is appropriate for everybody together to build team unity, because obviously we're all working together and trying to achieve the same thing. And then some is not appropriate for everybody together because of the different scope of practice.
Yeah.
And we can speak more about that term, that scope of practice term that's sort of thrown around so much. Yeah. But what would your general suggestion, obviously broadly speaking, be in terms of necessary team-based training?
So look, there's two. There's a multi-pronged approach there, and there's 2 aspects we have to consider. First of all, there's training on the clinical platform, and then there's undergraduate training. So in our educational system. So if we start with the undergrad system, I mean, most medical schools exist with a nursing department, with a department of occupational therapy. You have access to everybody in the healthcare team when you are training, but there's not really a concerted effort to bring those students together. And I think if we were serious about it, that's what we would be doing. And I know many institutions are trying to figure out how to do it, because obviously timetabling and everybody's curriculum is more important than the next, tends to take precedent. But I think that's where the key is for stopping the problem before it happens. Because once those students go out into practice, they now are forced to interact with the rest of the team, having no clue as to where your boundary ends and where mine begins, and where I can find value in this team member. So I think undergraduate training is very important. Then on the clinical platform, there are so many opportunities just with basic emergency care. So, in one of our community healthcare centers with this project, we got a phone call from one of the doctors, and she said, "I want to know what's going on, because suddenly there's this change in our nursing staff, and I work at another clinic where it's got the complete opposite. So I want to know what you're doing to our nurses that's giving us this amazing change." And we said, "We're running this course." So she said she wants to come. She wants to join the course. And we said that's fine, because it's for all levels of healthcare provider. And she joined the course. And she actually said it was so useful for herself. It wasn't it the basic emergency care course is designed to be able to meet every healthcare provider where you are at. And even if it's a refresher on, basic stuff you may have forgotten about emergency care, because we must remember these aren't emergency medicine physicians or trauma specialists. These are medical officers and interns working in these settings. So she loved the course, and we did it in a multidisciplinary setting. We had nurses of all categories and the doctor. And as we've been rolling out training with the Department of Health, we're doing mixed training. We've got doctors and nurses in the same classroom together. And what that does is, first of all, the doctors get an opportunity to get some insight into what the nurses know. So now you know, oh, this is a professional nurse, and oh, they can actually answer some questions, and what can they do and what can't they do. And when we do skills demonstrations, we often have to go through, this is the scope of practice for a professional nurse. We have a nursing assistant in our team at the moment. You're not allowed to trip, but what can you do? How can you prepare to assist the team? And that gives an opportunity for everybody to learn, what is my skill set, where can I add value, and people get to know each other in the team. So the course itself is great for that when it's multidisciplinary. We obviously, it's difficult when you're the facilitator, because you have to meet everybody at a different educational level, but it's not impossible because we've done it. And then the second opportunity that I've seen is with simulation. So I know emergency medicine does a lot of simulation, especially in their clinical platforms. I recently attended the simulation launchpad course with UCT. And it was actually with a whole bunch of emergency medicine consultants and registrars who all do simulation in their teaching and on their clinical platforms, so in the EDs that they are responsible for. But what was interesting is that when they run these simulations, they never include the nurses. They don't include the team. And it's so easy to do. Even if it's 1 out of 4 that you run with your emergency medicine physicians, invite the nurses on your team to join. You learn together. You learn how to communicate together. They'll be able to tell you what they can do and what they can't do. And it can be very basic. I mean, you can run a simulation with a very basic course, and the objective would be just for team dynamics, communication, understanding skill sets. So there are opportunities. It's just about using them.
And I also feel the I love simulations, but the one unrealistic thing about simulations is that they tend to happen on either a course or a teaching session of some sort, like it's a morning teaching for everybody type of allotted time slot, and everybody's there, and it's usually at the beginning of the day, etc. And then all of the actual times when you need the simulation training for the resusces or the clinical situations, either it's just you, the consultants have gone home, the nurses are stretched, there's 3 other people ventilated with one professional nurse, you've got You're asking a porter to fetch you something. You're asking staff nurse to draw up medication. You're sort of explaining it as you go. You know what I mean? It's all, it's not how it happens in real life. And I feel like a more inclusive simulation training would make that a lot better because again, you know what people can and can't do. Would you agree with that?
Yeah, absolutely. Because I think, I mean, some of the trends in the rest of the world are that people actually use simulation even before they open up units. They use it to prepare their staff for all different types of situations and scenarios, and they include everyone in the team, right up until the porter, the cleaner, so that they can become practice ready. It's almost like deliberate practice, and what you get from that is real time development of a team. It's not you go and do a course and I'll go and do my training, and somewhere in between we need to come to the middle, because it's what we end up doing is we don't capitalize on the skills that are available in our teams. So for instance, I'll give you an example. An emergency nurse on a team is able to monitor, assess, intervene. Their skill set includes from suturing and insertion of an IV line up until intubation and insertion of an intercostal drain. They have a very large skill set, which isn't known because in our big level 1 trauma centers where they all work, you have interns, you have students, you have medical officers, you have emergency medicine trainees who are doing all those skills anyway. So those nurses put those skills in their back pocket and they become scribes or sister one, as we call them. Whereas if you put that nurse in a CHC, she's going to use every one of her skills because nobody else is able to do those things. And it's sad because we don't know what investment we're sitting with in our teams because there's no opportunity for it to be used and we don't know. So we treat everyone the same, and even the emergency nurse who has all these skills is downgraded to a runner. You kind of just a task completer, whereas there's so much more that you can do with your team if you realize what is available. So I think it's important, especially for people who are leading those emergency teams, to know who's on your team and what can they do.
And that speaks to one of the questions that I was going to ask later. I feel what you do on a daily basis, regardless of your trained scope of practice, is very dependent on where you work, and especially based in a primary care setting versus a tertiary facility and or a secondary hospital, etc. And that's a two-way street, I feel, because obviously, if there's somebody else that is more senior to you, naturally, subconsciously, if you perhaps not confident enough in your skills, you're always going to defer. You're going to take a back seat and you're going to defer that task to a level above you. And if there isn't that person, then obviously, if the buck stops at you, you're going to do it because you have to. And I find in resus situations, like the same person in a different place would be leading a resus, and now they sort of get frazzled and they don't know what to do and call the doctor quickly because there's a doctor there. And so how do we address that? And I suppose you've spoken a lot about addressing that already, and it's just about communication and knowledge.
Yeah, it's amazing. The literature talks about nurse hesitancy towards resuscitation in general. Nurses in general run away from resusces. And I'm not talking about the emergency nurse. The emergency nurse is a special breed of nurses who actually like emergencies. The rest of nurses generally run away because they're not confident, because they're not sure of their place in the team, because they're not sure of their skills. It's not something they get to practice often. And that's the one thing that we saw with this very basic training, is that confidence increased amazingly. And not just, post course, oh yes, now I feel confident and I write that on a survey. But when we actually went back to the clinics, they say, I'm now confident, I don't wait for the doctor, I start and then I call the doctor. I'm able to recognize if a patient is deteriorating. And it's corroborated by the doctors who are saying, it's amazing, I get there and the IV line is already started. I have nursing assistants bringing people to the front of the queue saying, no, this one needs to be seen now, and they already know what needs to be done. Just basics. But what it does for their confidence is amazing. And I don't think you realize how much it means to a nurse to be valued in a team. So one of the nursing assistants, not even one, a few of them in our interviews said, it feels so good to feel a part of the team, because before I was just a runner. I didn't know what was going on. So I didn't understand the medical diagnosis. I didn't understand what was going to be done. I didn't understand the interventions. And now just because I understand it, I feel like a valued part of the team. So yeah, it's amazing what a little bit of training, a little bit of teamwork can do to improve the clinical processes in our emergencies.
And like you mentioned earlier, that doctor who contacted you with the discrepancy in the two units, I feel that that explains a lot in terms of people stepping back to doing a bare minimum versus stepping forward and taking a bit of initiative. In a normal situation, I think without any training and in any job, in any profession, you get people that naturally steer towards either side of that spectrum of wanting to take initiative and wanting to learn more and wanting to stick your neck out a bit. And then you get people on the other side who know what they can do, and that's what they stick to. And they won't do more out of sort of personal preference or policy or whatever you want to call it.
Yeah.
But I think if you empower people to do that, or if you give them a bit of a head start with some basic training, you would see a very big culture change, like what happened in your experience.
Yes, exactly. And the aim is to push people to do what they can do. And I think that's something that we've reiterated in our training courses throughout the start of the project and even up until now, is that we say you do what you can. And there's quite a lot that you can do, even with the most limited scope of practice, even if all you need to do is identify the deteriorating patient. That's fantastic. You've done what you can do. Um, and it's about giving people the confidence and letting them know that what they are doing is valuable. Because often people don't see the value in what they're doing. And so that's why it's not important. That's why making sure that the BP machine is calibrated and everybody doesn't have the same blood pressure for the next 200 patients. When you don't understand the value of the reading,
Let alone respiratory rate.
oh no, that's a different story because we can't blame the machines for that.
That was a joke. That was a joke. Yeah.
No, and it's a good one because it's actually something we bring up when we teach in the basic emergency care course, because we say to people, respiratory rate has such a huge implication on how to intervene with the patient. If you make it up, you are putting that patient at risk. Because we know what nurses do. It's very interesting that so many patients have the same respiratory rate in a unit. Everybody's got about 18. Um,
Well, you say that. Whenever it isn't 18, we actually take note, as it means that the triage nurses actually counted, and that means that they probably thought the breathing was abnormal, which does actually help in a sort of backward way.
yeah.
Moving on, um, nursing from an outsider's perspective is a very hierarchical, protocol-driven field, with the matron being the queen and then everybody else in ranks underneath. And it seems to be quite difficult compared to other fields to try and change something or try and bring up a good idea or try and be a bit innovative, so to speak, because of protocols. And protocols is another word that annoys me quite a lot, because a lot of these protocols don't actually exist when you go asking for them. It's just how things have always been done. What advice would you give? Because I mean, as someone yourself who has been very innovative and gone on your own journey, what advice would you give to other people and other nurses who are trying to change things, be innovative, and make a step forward?
Yeah, so just to affirm what you're saying, it is very hierarchical, and
It's the way nursing was designed in its very early days, where it was almost because it was a response to war. There was always the military background that it started in, that there had to be these ranks and orders, and obviously it's persisted right through in the culture. And I mean, there was a matron of one hospital that I worked for. I had a nickname for her. I called her Sergeant Major Matron. I mean, I would say a name. I won't say a name here because she had that persona. She was not in the military, but she had that persona,
Yeah.
and it actually it's starting to be researched now more and more, in intergenerational disciplinary teams, and how we educate the young and how we integrate the new generations into nursing and professional identity. And it's quite interesting that nursing has now this huge gap. We have a whole cohort of nurses that are retiring, a massive amount that are on the edge. Then you have this like kind of missing middle age group who all did nursing and then left the profession. Then we have all the young nurses coming in. And I think as the young nurses are coming in, they have to be equipped with the ability to think innovatively. So it goes back to education. And then there has to be some, thinking as to how we integrate people into our teams. So at an organizational level, now not at an educational level, at an organizational level, there should be managers should be thinking about the age dynamics in their teams and how they can harness the innovation of the young while still using the experience of the old, because there's a gap, especially in nursing. And if we're not intentional about how we bridge that gap, it's just going to get bigger. And then you have unhappy young people who, again, will just leave the profession like the previous generation. So it's an important question. We don't have all the answers because it's a difficult one, but it must be intentional. Otherwise, we're going to lose all our young nurses.
Let me ask again, you've mentioned some things, but how do we better teach doctors how to understand the different roles and the different qualifications of nurses? Because wherever I've worked, it's a very, very, very poorly understood thing. And it just doesn't seem to change in different places. Even if people wear epaulets or things, it's just not understood.
You have to ask. That's number one. You just have to ask sometimes, I don't think we have to teach anyone anything. We just have to teach them how to ask, how to talk to people, how to say to a nurse, where did you study? Did you do a degree? Did you do a diploma? What are you allowed to do? What are you not allowed to do? Something as basic as talking to someone in your team, I think shouldn't be overlooked, and we shouldn't overcomplicate it like doctors need another course in understanding nursing epaulets. They just need to ask.
My challenge is go chat to a nurse.
And on the other side of the story, nursing asking different things of doctors that are also completely on different levels of their training pathway, or on different teams that happen to be walking through the units and things like that. I think that name badges could go quite far, or like a name badge with a qualification. But again, like you said, it would probably be better just to talk to more people.
Yeah, I stick by that. I think talking to people makes a huge difference. And once you get to know your team, you automatically going to improve your resources and your team dynamics.
Most of the time, the simplest solution is actually the best solution. If you had a magic wand and you could wish for anything to sort of tangibly materialize in South African healthcare, obviously particularly with regards to nursing, what would that be if that could happen overnight?
Wow, that's an interesting question. I think many of our problems in the healthcare system are caused by things outside of the actual healthcare provider's control. Like there are many things that we could always do better. Nurses could be nicer. Doctors could be nicer. Everybody could be friendlier and happier. But we probably would be happier and friendlier if the system worked. If the resources that were allocated were used responsibly and for the right thing. And if our schooling system was better, it means our training would be better. It means our critical thinking would be better. So there's so many things systemically that I wish we could change. But if I had to wave my wand overnight, I'm going to be controversial. And I'm going to say I would wish for a first world functional NHI system where everybody has access to fantastic healthcare, and those with medical aid are not prioritized above those who aren't, and even those with medical aid on their own middle class incomes, and those who don't have medical aid do things as ridiculous as having to sit in a queue from 3 a.m. to get a number in a line to be seen. So I wish that we could wave away all the inequality and everybody could experience the same system, and that the system would be functional. So yes, I have an idealistic view of the NHI and I wish it worked.
And do you feel that as a professional nurse, the NHI would go to empower you to, or people within your qualification to practice better or more holistic clinical medicine, with the whole idea behind the ideal practice and the ideal clinic and the multidisciplinary approach being core to the NHI's goal? Do you think that would improve teamwork and multidisciplinary practice approach?
In theory, absolutely. Yes, we have very good theories in South Africa, very good ideas on paper. The problem would be when it doesn't work, when the resources are not allocated correctly, when private practices start to suffer because of not being paid, or and then you'll have a breakdown in the system more than an improvement. And as much as we hope that it will improve clinical care, I think those are the things that are currently affecting clinical care at the moment. The fact that there are no resources, the fact that people are unhappy, the fact that people aren't paid, the fact that doctors don't have jobs. All those things are important issues that if they're not addressed, clinical practice isn't going to improve anyway. So in theory, yes. In practice, I'm not so sure.
And what do you feel as a nurse? What do you feel the main difference between private and public and your general work experience is? Because I feel doctors alike, one's whole persona can change when there's money involved, when there's obviously resources allocated, when you're providing a skills for money transaction, or people are emphasizing your customer care, for lack of a better word. You get all of these friendly people in private who are doing all the things, and the nurses are nice and they're there and they're putting up drips and they're sort of offering you a glass of water while you wait, all sorts of stuff. And then the doctors come around and they're friendly. And in public, the same nurse who's just done a agency shift in private, or the same doctor who is locuming in both situations. It's just, I mean, it's very circumstantial, obviously, but it goes to show what effect it has on us.
Yes, and that's exactly it. And it's not so much the financial incentive, because nurses actually get paid better in the government sector than they do in the private sector. The difference, though, is that there are resources available. So if I have to put up a drip, I'm going to find an IV line, I'm going to find the right gelco, I'm going to find the right vacuolator. I don't have to worry about that. And secondly, there's such a big emphasis on quality control, and it's actually micromanaged in the private sector because it's customer care focused. In the public sector, I think what's happened is that there's developed a culture of we don't have. It's almost like we are doing you a favor by offering you this service, and therefore you have no right to complain about anything. And so that culture has bred in nurses, in doctors, and unfortunately, part of it is compassion fatigue. So that's a huge concept that's being researched in healthcare professionals abroad, and especially nurses. They have something called compassion fatigue. When you see the same thing every day, over and over and over, and you are helpless to intervene. Like, I don't have the resources. I can see the system is broken. I can see this patient's not going to get the help they need. At some point, you do detach. It's almost like a type of burnout, an emotional burnout. You detach. And when you detach, you develop compassion fatigue, and you don't care anymore, because if you did care, you'd be overburdened. So in a setting where there are resources and you can see results, you can see patients who get help and get good help and recover and get well, and there's no ethical dilemmas about who are we going to treat today, do we have enough ventilators? No, everybody just gets the right care. Then you are motivated to continue giving good care. But when there's this constant helplessness, you eventually don't care, and the culture just continues. And I say that not as an excuse. It's not an excuse for poor care, for being incompassionate or being rude or being unsympathetic, but it gives you a bit of a perspective as to what a nurse has to go through every day when you don't see change and you just become helpless.
Yeah, and this, I think, especially nurses get the brunt of that, because patients tend to speak. Healthcare providers can be rude. I'm not saying we are not ever rude, and sort of confrontational or dismissive, especially, is something that people struggle with a lot. But patients speak very differently to nurses than they do to doctors. And I feel that nurses often bear the brunt of patient fatigue and stress and plain rudeness. I mean, patients are, we try and give a patient-centered service and experience, but as you're saying, there are healthcare provider perspectives that need to be taken into account. What would you say regarding that, and your personal experience of how different people are treated by patients?
Mm-hmm. Well, I mean, it's quite interesting, because the power dynamic between doctors and nurses, I think, is a historic one, where doctors are just viewed as the one with the power, the one who's able to get me the care I need. And so nurses are obviously then second to the most important, because you see, even for instance, in getting the right prescription, in getting admitted, in getting to the service you need, doctors make all those decisions, and patients are aware of that. And so they will respond differently to a doctor than they will to a nurse. Besides all the historical background of, doctors and nurses, and the patriarchal view that has persisted across the years.
And let alone race and gender and all of that.
And all of that. I mean, it's amazing to see a patient, how they respond differently, because we have a history in South Africa. We have a history, and that hierarchy of race and gender still exists, even in a patient's mind. Even in a young South African Black person's view, they will still have certain biases and hierarchies in their mind. And I mean, we did a study not so long ago at one of our secondary hospitals on community service nurses and their experiences on their first year of service. And that's one of the things they spoke about. They spoke about how they watch people get prioritized in patient queues because of the color of their skin, and how certain managers who were a different color were treated differently. It was so interesting, because it's not something we went looking for, but this is what came out over and over, that there still exists that those racial biases in our healthcare system. And if we don't have the conversations, then it'll never be addressed. But I always say it's up to the professional to start to change it. I teach undergrad students, and the buzzword since fees must fall has been transformation and decolonization of the curriculum. And I say to them that they have big ideas, but big ideas start with one person. And if you are so passionate about transforming the healthcare system and ensuring equity and getting rid of racial biases, it starts with you. It starts with the care you provide. You can give back a person's dignity. You can give back a person's autonomy. You can show them respect to the point where they start to actually believe that there's equality in the service that they're accessing. But it starts with just you as the professional. It doesn't have to be a big protest and a political movement. Just if we just teach our professionals how to transform their own practice, then we'll start to see a difference.
Very well said. I think that's all from my side. Thank you so much for joining me. I'm sure our listeners, both doctors and nurses, will find that both very interesting and inspiring. So thank you.
Thanks, Dan, and thanks for having me.
That's all for this episode. To summarize, we started talking about Meghan's ongoing research and the implementation of the WHO Primary Emergency Care Training Program and all the expected and unexpected benefits that they've seen so far. We spoke about how communication goes so far in developing team cohesion and better outcomes for everybody. And we discussed the hierarchical system of nursing and how young nurses can still be innovative. We also then chatted about patient and healthcare worker perspectives and prejudices that have deep roots in South African and global history. And that's about it. So be sure to subscribe on all of your main platforms and send this to a friend or a colleague who might be interested. If you want to get in touch, find me on LinkedIn or email me at dan@badem.co.za. Please also follow us on Instagram and Facebook at Brave African Discussions and X or Blue Sky as badEM. Thanks for listening. See you all next month. Bye bye.